Hello, and thank you for joining us. My name is Chiquita Brooks-LaSure, and I'm the Administrator of the Centers for Medicare and Medicaid Services. Across our programs, Medicare, Medicaid and CHIP, and the Affordable Care Act marketplaces, CMS provides health coverage to more than 150 million people across the country. Our programs drive quality control and oversight over the bulk of the U.S. healthcare system. When we talk about building a more equitable healthcare system, we mean it. As the first African-American woman to serve as CMS Administrator, I outlined advancing health equity as my first priority. For me, health equity means the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, or other factors that affect access to care and health outcomes. This Black History Month, CMS is recommitted to working to advance health equity by designing and implementing and operationalizing policies and programs that support health for all the people served by our programs. We want to eliminate avoidable differences in health outcomes experienced by people who are underserved and provide the care and support people who rely on our programs need to thrive. The COVID-19 pandemic has emphasized and exacerbated systemic gaps in healthcare, particularly for the Black community, which is at greater risk of severe illness and death from a variety of illnesses, not just COVID-19, due to historic inequities in access and quality of care. In April 2020, my own hometown, a predominantly Black community where my parents still live, experienced higher rates of COVID-19 infections and deaths compared to much of the surrounding communities. These failings are not new, and they didn't just appear on the heels of a pandemic. This inequity leaves millions of people unable to access the care they need. For example, in 2018, life expectancy among Black people was 4 years lower than white people. And due to COVID-19, Black people saw a decrease in life expectancy of 2.9 years, where white people experienced a decline of 1.2 years. And African-American women die of pregnancy-related causes at approximately 3 times the rate of their white counterparts, and face more severe complications from pregnancy or childbirth than white women, regardless of their education or income. The Biden-Harris administration and the team at CMS is working to address these disparities and advance health equity. Yesterday, the Department of Health and Human Services released a new report that showed historic gains in healthcare coverage and affordability among Black Americans. This report showed that since the implementation of the Affordable Care Act's coverage provisions beginning in 2010, the uninsured rate among Black Americans under age 65 has decreased by 40%. Through the Biden-Harris administration's actions over the past year, we're building on that progress by expanding affordable care options through American Rescue Plan subsidies, a marketplace special enrollment period, and enhanced outreach to Black Americans during the recent open enrollment period. We're tackling the maternal health crisis by working with states to extend postpartum Medicaid coverage to 12 months after birth. And we've proposed a new birthing-friendly designation for hospitals to encourage facilities to learn from one another how to improve health outcomes. We're strengthening our data collection requirements, including data for populations defined by race and ethnicity, disability, rurality, and other demographics across Medicare, Medicaid, and the Affordable Care Act marketplaces. I believe that we measure what we care about, and additional race and ethnicity data will help us drive decision-making and measure our success. It's a big job, and we can't do it alone. Fortunately, we are not. CMS has trusted partners in communities throughout the nation, partners like historically Black colleges and universities, and healthcare advocates who are uniquely positioned to help address injustice in our healthcare system. You'll hear from some of them today. HBCUs play a critical role in building a strong pipeline of talented healthcare providers and public health experts. In 2021, CMS provided research grants to Florida A&M University and Meharry Medical College to explore how CMS can improve health outcomes in disadvantaged populations. And in the early spring, we'll continue that support of minority-serving institutions like HBUs with additional funding to research ways to advance health equity. It will be the largest amount of funding that CMS has released in years. I want to close with a bit of context. Historically, Medicare and Medicaid have been pivotal in disrupting systemic racism in healthcare. Flash forward to 57 years ago, and you'd see in hospitals in the South operating under Jim Crow laws, either refusing Black patients entirely or segregating them to the basement and providing unequal care. This isn't ancient history. When I gave birth a little over 8 years ago, my husband was in the waiting room and spoke to some Black women who were sitting in the waiting room and asked if they had been born there. And they said, no, we were not permitted to be born in this hospital, even though they lived around the corner. Meanwhile, in the North, African-American patients were sent away from hospitals dominated by whites to either county hospitals or historically Black institutions, which often operated with few resources. Upon its passage by Congress, Medicare threatened to withhold funding from hospitals practicing racial discrimination, and this practice changed almost immediately. Dedicated civil rights champions serving as hospital inspectors encouraged thousands of hospitals to desegregate within just months of its passage. MLK had it right. Injustice everywhere is a threat to justice everywhere. And in my eyes, healthcare is a civil right and it's a human right. Today, we carry that legacy and we're working every day to defend that right for people. And now I'll turn your attention to a short video.
As an HBCU, Florida A&M University has had a long history working with the community and with minority populations. I looked at the numbers, and from the numbers that I've seen, the Medicaid population here in the state of Florida, especially when it comes to births or deliveries, over 60% are African American and 8% are other minority populations. So if you're trying to make a difference and have an impact on that particular group, then that group is a group where generally they're underserved and they have poor health outcomes. So that's actually where you want to start. Much of the research grant that I have is actually dedicated toward working with students and getting students involved in this research so they can carry on even long after I'm gone and they can train other people. So I think it's important that grants also provide an opportunity for other students that are interested in this type of work to be involved. It is a opportunity for students to learn how disease works in a population and bring that knowledge to working as a physician.
One of the things we're seeing in the research space is sort of the issue with big data and the use of new technologies and analytics from artificial intelligence and machine learning. And we want to be able to introduce some of the early stage investigators, particularly at our minority serving institutions, and to help them become familiar with these techniques and with the CIMS Medicare Medicaid data. The Medicare and the Medicaid data, is probably the largest data set that's out there, again, for conducting health services research, and we hope to be able to train young investigators to use this to conduct health disparities research and to be able to look at differences across racial ethnic groups by using the claims data and again the pharmacy data and for prescription drug data, those sorts of things. In terms of training minority investigators in the area of health disparities, we're hoping to be able to shed some new light on issues that have been looked at previously, but from different perspectives.
Now it is my pleasure to introduce our panel members, Dr. Kimberly Weiche, Anita Jenkins, and Dr. Ala Stanford. Dr. Weiche serves as the Senior Vice President for Health Equity for the Association of State and Territorial Health Officials and co-principal investigator of the HBCU Wellness Project at Meharry Medical College. Ms. Jenkins serves as the CEO of Howard University Hospital. She is the former president of Sycamore Medical Center and serves as COO at Ketterling Medical Center. And Dr. Stanford is the founder and CEO of the Black Doctors COVID-19 Consortium. Their grassroots efforts have worked to shift and improve how medical services are delivered. They have treated over 100,000 residents in Philadelphia and surrounding areas. To Dr. Weiche, as I mentioned earlier, one of our key priorities as CMS Administrator is to address health equity and ethnic disparities in healthcare and advance health equity, especially in terms of maternal health. We'd love to hear your ideas and potential strategies for CMS to further those goals.
First, thank you for the opportunity to join you today. It is a pleasure, and I'm so happy to see this important subject being addressed. As a public health physician, I live in an interesting space where I'm able to use my public health knowledge in the exam room as a practicing doc. And when I think about how we were trained versus as just traditional physicians and how we're trained if you actually have a public health background, I realize that I look at the world really through a socio-ecological model. And when we think about the health and well-being of women, especially Black women, in order to improve and to see different outcomes, we need to approach that at multiple levels. From the individual level, we need to increase self-efficacy and make sure that women are the best advocate for themselves, they understand their bodies and giving them the ability and the words to be able to describe what's happening to them. From the interpersonal level, understanding and realizing the importance of implicit bias and how it can affect health and healthcare for women as they enter into the healthcare system. As you mentioned just a couple of minutes ago, from the organizational standpoint, looking at structural racism and how do we eliminate that to make sure that all women and all patients have the best access to all health care. And then from the environmental standpoint, so many of our women are living in communities that don't have the environmental factors that lead to good health, whether it's access to healthy food, whether it's safe air quality, whether it's a protection from dislocation or from being displaced, as we're seeing in so many areas, along with the threat of gentrification. And then from the policy standpoint, making sure that we practice health equity in all policies, whether it's from housing, whether it's from healthcare, for everything. If we're able to create an instance where health equity is the default and not the exception, then all women will experience an improvement in their health care. And I think that CMS is on the right path to starting that by encouraging health equity at all levels.
You've really shown us how important community-based organizations are to providing equitable care and helping to rebuild the public's trust in government. What are opportunities for community-based organizations and CMS to work together, especially to increase access and quality of care for people who are covered by Medicare, Medicaid in the marketplace?
Administrator, I believe, was that question directed to me? I didn't hear. Okay, wonderful.
Yes.
Good afternoon, everyone. CMS, one, we appreciate that you exist because at least there is a way for folks to have that access, if you will, to get to a provider. But other things are the personnel that are there when they arrive there and increasing the number of clinicians that represent the population that they're serving. And it doesn't mean that every doctor has to be Black or of color, but they have to have a certain level of cultural humility. And I'm getting away from cultural competence, but cultural humility, which means you can take a moment to see the steps that this individual is walking in. Also, when there are entities that are working, for example, the Black Doctors COVID-19 Consortium now will be 2 years next month, and we shifted from just doing testing and vaccination and now providing primary care, that the support is there for those entities, be it financial, be it personnel, so that we can serve people in the community where they live, where we are an annex to a church and across the street from a high school, and we're behind public housing, and we are on an access for all public transportation and near a strip mall and daycare centers that are walking distance. And when you have that, it allows for not just the child to be cared for, but the parent and the grandparent to be cared for. And so when you identify sometimes the non-traditional community-based organizations, that the support is there in those ways I mentioned, and then duplicate it so that it can be done in other communities to have favorable outcomes.
Thank you. I'll now turn to Ms. Jenkins. Given HBU's unique role and strong relationships with communities of color, what opportunities do you see for them to help reimagine and rebuild our healthcare system in a post-COVID world?
Nothing was more eye-opening than to experience COVID-19 at this organization. As a matter of fact, I started February 17th, 2020. By about March, I did ask the Lord what was his timing all about. And because I started just in time to see exactly how our community responded to COVID-19, their education about it, their response and trust in healthcare. What we have as opportunities afterwards is to build a stronger relationship in every way. Of course, teaching and training, HBCUs, that portion is that we are training Black and Brown physicians to be that healthcare partner with the community that they serve. My daughter is a physician in Ohio, and now people seek her out because she is a Black female physician. It is important for us to build those kinds of relationships. That's what people have had all along, but not necessarily people of color, where they could trust and understand, where they could ask honest questions, where they could tell them the truth about their life, their situation, their mental health, and their current physical situation. That trust is what builds and increases and improves the healthcare outlook. On the other side of COVID, we have got to get back to routine healthcare, screenings. We are seeing heavily that people have ignored routine healthcare and screenings, and cancers were missed, or mammograms that identified something very small that could have been treated. We are now seeing that that people are in dire straits, and people of color particularly. It is so important for us to get back to basics, to talk to people about their health and how they are living, their mental state of mental health and food. I had the opportunity to go into the most needy environment in Washington, D.C., for the lack of a better term, and be on a cooking show. I've always cooked. I've always done Southern cooking. Now, when I told my children I was going to do a cooking show, they were like, "You're going to back off the gravy, Mom, and the macaroni and cheese." I did cooking. I did cook some healthy foods. But to teach and train people who have minimal means how to eat healthy. That collard greens and beans and rice and yams is a very, very healthy meal. And to think about how we can help people on minimal incomes with their food, with food distribution, with healthy eating, teaching, breastfeeding, prenatal care, and mental health. We've got to get back to those basics. And then when they come in for screening, we can do more, we can make more progress. It is a huge menu of how we can influence everyone. So that's not in our scope of care. I don't get compensated for that. We don't get compensated for that. With CMS, maybe we can think broader of how we're providing healthcare, because I'd rather have a healthy baby and have my hospital with screenings than to deal with people who are just very ill by the time they come into our ERs.
Absolutely. You've raised so many critical issues. And as you know, our role at CMS is really about coverage. And it's not just the acute illness where we want to treat people at the end, but getting people in for screenings. We're seeing that, as you mentioned, because of the pandemic, for kids in particular, immunizations are way down. And yesterday we did a Black Cancer event with the White House, and really emphasizing, particularly in our community, how important it is to get screened, to get people in for routine care, and those broader scopes of issues that you described. So thank you. I'm going to shift gears just slightly and turn to our two doctors and really ask your perspective on the fact that there's just no secret that there's a dire shortage of medical professionals, especially in underserved areas. This challenge existed before the pandemic, but it's gotten even worse. And, it's something we're really focused on because lives will be at stake if nothing is done. Are there ways that CMS can encourage more providers to enter the medical field, and in particular to practice in underserved communities?
You want me to start, or go ahead?
So, when I was finishing medical school, there were all these incentives and encouragement for folks to go into primary care specialties. And we know the number one cause of death is cardiac disease. Number 2 is cancer. Right now, COVID, and 4 casualties and trauma. All 4 of those things are subspecialists that treat them. You need good cardiologists and cardiothoracic surgeons. You need good surgical oncologists and internists. And of course, you need our infectious disease, and you need traumatologists, and you need psychiatrists to deal with the emotional and mental health that's being faced. And so focused and giving support to people who are subspecialists, I think would help. Also, as we build the pipeline, honestly, by the time kids are in college and med school, it's too late. Those kids have already gotten through so much adversity. I think it needs to be sooner, perhaps even elementary school, because you can identify diamonds in the rough in some of these urban areas just with their standardized test scores. And then as much as you identify folks at HBCUs, there was also a lot of folks at non-HBCUs that are doing the work. And all those things there are myself. I'm a board certified pediatric and adult general surgeon. That's not primary care. I went to Penn State undergrad and for medical school. And I am in the heart of North Philadelphia and have been taking care of people of color for 25 years, but especially right now. And so I think thinking outside of the box of who are the people that are going to go back to their communities and take care of them is one very big way that will help, because none of the typical folks that are supported by the CMS and federal government, I would not have checked any of the boxes, but here I am.
You bring up such an important point, which I was going to mention, in the fact that even as a result of COVID, our pipeline is so leaky at this point. We have generation of students that are behind academically. They have missed out on so many opportunities. And now that we're saying, and fallen out of the STEM careers, we'll say. And so when we get to the point of who's actually applying for medical school, those numbers have decreased. We have our public school children who are going to be competing with private school students that were out of school for maybe a month, and test scores are going to come back. And so we really need to know how to support our younger children. As a pediatrician, I'm a firm believer in middle school students. Everything starts in middle school. How do we encourage our middle school students to stay in STEM, especially our young women of color that tend to drop out of STEM careers during middle school, so that when it's time for for medical school, they will apply. But also the fact that so many of our students are deterred from going into primary care, where they're also needed because of debt. They've realized that they will not ever get out of debt if they go into adult, internal medicine or pediatrics, and they're pushed towards specialties because of the fact of the amount of deaths. And as you said, many are diamonds in the rough because they haven't had the exposure or the experience in some of the inner city schools or some of the lower performing schools. They're still brilliant. They're still there. They just haven't had the opportunities. And finding them, nurturing them, and helping them to the finish line is something that will definitely help. If we double the number of students of color, some of them are going to go into primary care. And those students that go into primary care will be more likely to work in populations that are underserved or under-resourced, and allow us to find some of those chronic diseases earlier and decrease some of that disease burden later on.
Many thanks, Doctor. Might I add that we have to have a long game about the healthcare industry as a whole. I started my career as a respiratory therapist. We've got to get people who are interested in going into careers in healthcare and finding it exciting. Not everyone can be a doctor, although we need so many more of those. But to find nurses, clinicians, physical therapists, speech therapists. I was challenged at one of my hospitals to improve the physical therapies diversity numbers. And I could not find any diverse students in the schools that fed our hospitals. And so I think Dr. Stanford said, we've got to go back to middle school, or maybe Dr. White said it. It starts in middle school. Get them interested in that. So we've really got to push medical careers as a whole to increase how our healthcare facilities appear to the people that we serve.
You're so right to mention how important it is not just to support the physicians, but all of the other clinicians. We're spending so much time thinking about nursing homes and nursing home safety, and so many issues where there are, as you described so well, so many other supports in terms of our nurses and other parts of our healthcare system that really need to be encouraged for people to participate. Are there any other pieces that you all would suggest in terms of our role? I should mention that the CMS Office of Minority Health has funded a number of grantees to examine disparities in public health, giving increased focus on addressing social determinants of health. These grants will also help to increase health equity research at capacities at minority serving institutions. It's a real area of focus for us to look at social determinants of health throughout our programs and think about how we can integrate that into the Medicare program, into Medicaid and CHIP. We've seen a number of programs across the country really rising up in that area. And on the social determinants of health, recently approved a waiver in California to really expand coverage in an exciting way. And we hope a number of states will take a look at the the changes that California is putting in place to really address these social determinants of health. But are there any more recommendations you have to help people of color successfully pursue careers in public health and equity research?
I just wanted to add, when you talk about the social determinants of health and increasing the number of students that are looking at that, is that all determinants of health are not negative. But when we look at social determinants of health, we tend to focus on the risk factors. And we always say, if we're able to augment the positive instead of just mitigating the negative, we can probably get a lot further. So many of our communities are tired of being told that they're broken, that they're disparate, that this is bad, their outcomes, they're going to die, their babies are going to die, et cetera, instead of looking at what are some of the positives. When we were looking at issues of infant mortality and being able to say that our rates are extremely high at 1 out of 50, but that means 49 of those babies survive. So what are they doing differently? And how do we study the positives? But most people don't want to fund what's going well. They want to fund what's going wrong, what's going poorly. So being able to increase grants to look at some of the protective factors as defined by the communities that are most affected is one thing that we can do. At Meharry, we have, as I mentioned, our HBC Wellness Project, where we actually train college students under the direction of Lisa McGee to be student health ambassadors. And they go into the community. They're focusing on disease entities that they're interested in, whether it's infant mortality, obesity, diabetes, HIV, and they're working with those communities, doing IRB-approved projects to improve health. And over the course of the 10 years or so that they've been doing this, they have educated hundreds and hundreds of community members at the level of where the people are, doing things that so often the colleges, the hospitals, physicians, that we're not able to do. We're not able to be in the community as much as we'd like to. So being able to support projects like that, in another world, they might be considered to be community health workers, but community health workers is defined in many ways depending on that population. But being able to realize that all health isn't done in the exam room. Most of it actually isn't. And so just being able to support additional projects like HBCU Wellness as a way of getting information into the community. And a lot of those students, as a result of their work, have entered into the pipeline, which is very exciting.
I so appreciate that perspective. I think it's so often that as policymakers, there can be the perspective of thinking we know the answers and know what we need to do and how important it is. And something we're really trying to bring at CMS is integrating the perspectives of people with lived experience into our policymaking and those stakeholders who are on the ground. And you're elevating there is a lot of positive here that we need to build on and not assume the answer before we've asked the question is one of the things that I think we have to keep reminding ourselves, and why I like to say to the team, data collection is so important, not because we think we know the answer, but to actually evaluate, see what's working, and make sure we really understand what's not. So really just thank you. We just have time for maybe one more question. And I can offer it to be just thinking about, just really just giving you all a moment. Is there anything that we haven't talked about that you really want to make sure that we convey? And I'll just start with you, Dr. Waichi, since you have the floor.
I think just reiterate not all at the HBCUs, and to figure out how is there a way that we can identify those students who have the same passions but just chose to take a different path to be involved in this work. As long as there is a perception that disparity work, health equity work is only a minority responsibility, then we are not going to be able to achieve it. We have to be able to make it a default that it's everybody's responsibility and continue to elevate our HBCUs, because we know there's a propensity of students that are interested, but not solely their responsibility or our responsibilities to solve the those problems. There's so many students out there. I did not go to an HBCU. I'm doing disparities work. I'm at an HBCU now, which is a wonderful experience. But I'm similar to what Ms. Jensen said. I wouldn't have been able to check any of those.
Absolutely. Neither would I. And I think you're so right. I like to say where our Medicare is our big lever, and we need to make sure we're using it. Ms. Jenkins, final thoughts?
Just a couple of final thoughts. I was born and raised in Pittsburgh, Pennsylvania, and I now know that my mother had strokes, many strokes, untreated, died at 62. And if they had only been so much more aggressive of managing her hypertension and paying attention to her, but we have to just treat people with high quality. I don't know that it's a diversity problem amongst our medical team members, no matter where they come from. But I know this, our patients, no matter what color they are, should not be ignored. They should be given the education and training, build trust to make sure that they take care of themselves, take their medications, and avoid outcomes that you wouldn't want for your family member, no matter what color you are. We've got a lot more to do, and I'm excited to be with these amazing panelists to keep that fight going. I'm excited about the years ahead that we'll do better.
Thank you. Dr. Sanford? Any final thoughts?
What allowed us to be so productive during this time is I was a grassroots person in the community, but I also had a seat at the table with the Board of Health. So there was no delay in what was happening in the community getting to the policy makers. So we were able to make changes in real time based on the needs of the community. And I think more of that model needs to happen. The other is, yes, we're funding, or you're funding different grants and different projects, but when there is an acute emergency, there may need to be a shift, and that more focus was placed on the lives being lost with real-time, tangible action in the community. While many were waiting for funds to come, a lot of those resources could have been, with helping the people that needed it the most, as everyone identified it, but there wasn't enough action. And then specifically, a charge could be for all the Medicaid children and CHIP folks that are out there. You could create a scholarship at a very young age when they're born to identify potential children who are interested in the healthcare. Just send it out when you send their benefits and have the parents or guardians complete an application, and you could follow those kids, and there could be an additional stipend or something like that. And you could identify those kids based on income, based on zip code, based on trajectory, and follow them through. And that would be a real feather in the cap. And so I think there are ways to identify, as I like to call them, the diamonds in the rough. I was certainly a diamond in the rough, now working in the same community where I was born and raised. But I think the youth is where we will get out. Our future will get us to the next level. And I appreciate you shining light on it, Administrator Brooks-LaSure, and looking forward to what we all collectively do next to get closer to health equity in our nation.
Thank you all for this wonderful discussion. It's been such a pleasure to have you join us today to share your insights and perspectives. Sorry, just got something in my throat. It's really, it's really just such a pleasure for me to be with you and to hear from our partners. And as I think you said, Ms. Jenkins, and definitely as you just said, Dr. Sanford, it's just such a pleasure for us to, at this moment, have such an opportunity to work together on health equity. I really feel like we're in a moment in our country where there's a new recognition of the importance of us shining a light on it. So thank you so much for taking time with us today. We so appreciate everyone's intention.
My honor.
Thank you.
Thank you for the opportunity.
Thank you.
produced by the U.S. Department of Health and Human Services.